So how do you identify patients who are at risk for exacerbations, or are we simply saying that with the LAMA-LABAs we don't have to pay attention that much because they're going to prevent them? How do you deal with that?
Best predictors are history. We know that from her study. And like when you enrich your study, you want to study a drug that's reducing exacerbation. What they did last year is the big thing. 1 or 2 is a pretty good predictor, and maybe you could elaborate on it, Fernando.
So here's the way that I look. I've been thinking about all you guys have said, and having been a primary care doctor in a previous life, and thinking about how I would want to do this. Here's the way that I would conceptualize your 10,000-foot view, Peter, and then bring it down. First thing is, as Byron and Frank said, you've got to, in your own mind, try to get a sense as to whether you're dealing with asthma or COPD. Because if you're going to fall on the asthma side of the equation, it's symptoms, inhale steroids first, and then modifications based on symptoms and acute events. A lot of what we do in COPD is similar to that. In the COPD life, as Frank says, it's the opposite. It's bronchodilators first. And that's the first thing you're going to consider. Whether you consider a dual, one of these combinations first, or a single agent first is, as Frank says, dependent in part on the level of symptoms. If a person is having very few symptoms and you appropriately ask what that implication is, you could get away with a single agent. I think most of the patients probably will benefit from having a dual bronchodilator. Then the next series of questions you ask are, as you said, what are you doing? And what was Zawalik's?
How are you doing? And what are you doing?
And what are you doing? And then the extra question that we throw on top of that is, have you had any episodes that have required antibiotics or steroids in the last year? You know, flares, whatever those components. Because if the answer to that is yes, then as Jim says, that's where you see the best predictor in an individual patient for future events. And as we already said, preventing those future events is a key component. In that situation, you start considering a dual bronchodilator if they're not on one, or potentially inhaled corticosteroid, because those effects are predominantly in exacerbation.
How important clinically are exacerbations anyway? I mean, if somebody has an exacerbation, you bring them in, you treat them, you send them home. I mean, come on.
Well, so the exacerbations...
I'm not being facetious.
No, I mean, but actually that question is not infrequently asked. So when you talk to patients, they don't like these because they feel there's a loss of control of their life. They can sense that their disease is worsened. And so from a patient perspective, it has a lot of impact. Patients do not like exacerbations, and particularly those that lead to hospitalization. So the patient perspective, they don't like those things. And so they get a sense of the value of preventing them. The second component is a lot of what Frank has talked about in terms of the biology of disease. Many of the components relating to lung abnormalities, peripheral abnormalities, and comorbid conditions, many of those are actually worsened by exacerbation events. So for us, it's the patient doesn't like them, so preventing them is important. And by the way, preventing them has additional components that will have benefits on that progression of that disease over time. So they are important events, which is why almost all therapeutic guidelines now not only ask, what are you doing in the way that Dick Zawalik stated, but have you had any events in the last year? Because those two components are going to drive how you're going to manage the available therapies that we have.
So let me ask Fernando a question, because the holy grail is survival, right? And one of the reasons why everyone in the world is on a cholesterol-lowering drug, on the hypertensive drugs, appropriately, is that there are survival benefits. We have struggled with that from a medicine standpoint, at least. You know, yes, oxygen certainly, when indicated, does. Lung volume reduction surgery does. We've struggled from it. So exacerbations do all these terrible things. If we can cut down exacerbations, doesn't it make sense that we'll improve survival?
Yeah, and I think that you're absolutely correct. I think we've struggled with that in the COPD world. I think you're right. All of us would love to have a simple therapeutic intervention that clearly improved survival, as statins have done in the cardiovascular world. We're still moving in that direction, and I think that's an important component. But when you query patients now, they love the idea of improving survival, but they're going to want that quality of life and preventing those acute events as well.
I want to just maybe get the viewpoint of others. One of the things that's fascinating in the exacerbation, and again, event-driven kind of decline in lung function and quality of life is very important. But many people don't report the exacerbation. So if you look at some of the diaries from London, Dr. Vajija, and then some of the what's called the ExactPro data on exacerbations, it turns out that fully half of the exacerbations are not reported to the physician. Now, some of that is because they're so damn tired with the fatigue, they can't get up and get to the doctor. But a lot of patients have an incredible fear of losing control and not going to the hospital because so many don't come home. They go to skilled nursing or other place. So there's, and it's particularly in the more severe population, there's incredible resistance. And they might take a phone call, and if you gave them something over the phone. But I think that's a phenomenon you see in the more severe patients. And if everything is the focus on the patient in personalized medicine, you have to sort of incorporate that into your thinking. And the PCPs do that better than we do.
But they're getting cause and effect backwards, right?
Absolutely.
It's understandable.
Yeah.
But it's if I go to the hospital, then I won't come home.
That's correct.
And it's the hospital that they see as
That's
the
correct.
driver.
And again, because they don't recognize it's the severity of their disease worsening. And
the other thing I'm hearing from you guys, tell me if I'm getting this message right, is that okay, you get an exacerbation, we'll treat it, probably go home. But every exacerbation notches you down. Just
correct.
never
Exactly.
quite
Event-driven.
the same.
Yep.
Is that fair?
No, I like it. That's the way to put it. Yep.
Exactly.
With the caveat that one of the reasons for that is that patients notch their inactivity. So in my experience, and a concept that actually is proposed to be tested at the NIH, is if you begin rehab and exercise training immediately after an exacerbation, you may in part prevent that notching down. Because really only 20 to 25% of patients after an exacerbation have any persistent decline in lung function. So the majority of patients' lung function comes all the way back up, but symptoms often don't follow because they have that deconditioning
So
addition.
I can't agree any stronger than with what Frank just
really
said.
good.
He's absolutely correct. And I'll come back to this whole issue of hospitalizations and rehospitalizations because we do some bizarre things to people in the hospital. So you have these COPD patients who come in. Oftentimes they're debilitated to come in, and we're so concerned about their falling that we keep them at bed rest for the 3 to 5 days in the hospital. So they often leave more debilitated than they were before. And how much this sort of post-hospital syndrome actually contributes to readmissions is not clear, but it's something completely under hospital control.
You know, I can tell you, because I'm going to tell you a story out of school, because I was an attending in the ICU when he came by. And I learned something from this man, which was I had exactly that response. In the ICU, a sick patient, you said, get him out of bed. And I said, oh, come on, Byron. No, we got him out of bed. And you know what? They got better faster. So the point about identifying exacerbations is to treat them, get these patients going again. And to identify patients at risk, I would expect is, maybe I'm wrong, if you identify somebody at high risk for an exacerbation, is there something you can do a priori to keep that exacerbation from happening?
Well, I mean, I think that that's been one of our holy grails in COPD management, and some things do work. So as Byron says, long-acting bronchodilators have an effect in that respect. Inhaled corticosteroids have an effect in that respect. There are additional agents. The one agent in the last 20 years, a phosphodiesterase inhibitor, roflumilast, has an effect. Frank, we spent a lot of time looking at macrolides and azithromycin's effect on exacerbation reduction. And the combinations of those actually have incremental effects. So there have been a lot of therapeutic approaches that we currently have available that have been developed specifically for that reason, Peter.
Okay, now.
And they work.
Give me, if you can, before we move on, can you give me a checklist? A patient sitting in front of you, how do you say, oh, you're at high risk for an exacerbation? Maybe not so much. Is there anything to ask?
So, I mean, what's kind of funny is when you do these complex multivariate analyses, the thing that comes up every time is how many times have you had an exacerbation in the last year is the biggest predictor.
So past performance is a predictor of future
Very
performance.
strongly. And, you know, that's New England Journal worthy. Have you had exacerbations? You're going to have exacerbations because that's where it was published. The other thing that comes up frequently is allergic, asthma, eosinophilic features in a COPD patient is a predictor of somebody likely to have a flare-up, more likely to have a flare-up. And so that's probably the second most frequent component that comes into these analyses.
Right. So if I'm your COPD patient and I come to see Frank and Frank asks me, what are you doing? And I say, oh, I'm not doing anything, Frank. And then he says, and what have you cut down? I have everybody doing everything for me. He already knows I'm symptomatic. And then he's going to ask me, have you had any flares that have required antibiotics or steroids in the last year? Sure, but the last time I had one of those was 6-7 years ago. Don't you remember that? That's a low-risk person. If I say to him, Frank, you gave me 2 courses of this, you gave me an antibiotic 3 weeks ago, and you got steroids 6 months ago. Don't you remember that? Don't you look in your medical record? You get your EHR right there. And that's a person who's at risk for having future events.
There are a couple of others, though, that I think we all agree in which are important. The severity of the COPD.
Yeah.
So while we've talked about spirometry as a gauge of making a diagnosis, and we all understand it has its flaws, the more severe the COPD, the more likely you're going to have exacerbations, and perhaps more importantly, the more likely you'll end up in the hospital for those exacerbations. And then there's some other things like GERD, you know, that potentially might be a risk, you know, that people sometimes may not pay attention to. So there are a number of other factors, but I agree completely with it, Frank.